Welcome to another edition of Inside Your Miami Medicine podcast. I'm Ami Ford, your host, the Dean and Chief Academic Officer of the University of Miami Miller School of Medicine. This is a podcast where we explore fascinating medical research that is shaping the future of healthcare and healthcare delivery in general. So today, joining me in the studio is none other than the great Dr. Nima Sharifi, Scientific Director of the Desai Sethi Urology Institute, a member of the Sylvester Comprehensive Cancer Center, and Professor of Urology at the Miller School of Medicine. He's a renowned physician scientist whose work has led to seminal discoveries in the fields of prostate cancer, steroid metabolism, and human physiology. In this episode, we will delve into Dr. Sharifi's groundbreaking research on how genetic mutations fuel cancer progression and influence treatment outcomes. We'll also explore the critical role that lifestyle factors such as diet may play in the development of and management of certain cancers. Dr. Sharifi, what a pleasure to welcome you to the podcast.
Thank you so much for having me here, Dr. Ford.
Fantastic. Well, before we delve into your fascinating work, and I think it's going to be exciting for a captivating audience who wants to learn more about prostate cancer in general, tell us a little bit about your journey and how you managed to eventually become the director of the Desai Sethi Urology Institute, and why you even decided to come here. So take us from the beginning to now. in no more than a couple of minutes.
Right? No, of course. So I can start early on, perhaps in my high school years, my college years, where.
And where were you growing up?
I grew up in the Northern Virginia area, in the DC metro area. Great exposure to science, and I knew that I always loved to, had an affinity for the sciences, but it wasn't always clear to me that I wanted to do medicine or science. And it wasn't until perhaps the early years of college that I decided not just to do clinical medicine, but to become a physician scientist. And that early on, I was trying to decide between something in cancer versus something in the neurosciences. Eventually went to the University of Pittsburgh for medical school, right? Overlapped slightly there.
Yes, you were my medical student.
Yes. But that was great. And, it was a great, fantastic education. I also,
but even then, I mean, I remember you were a brilliant medical student, but even then you start some research, additional research exposure, Howard Hughes investigator, right?
Absolutely. So I spent a couple years in the lab, one before at the NIH, and then during, both doing work on genetics at the cellular level, and then a second stint, genetics at the organismal level, looking at how genes influence the physiology of mouse as it applies to human. And it was in that time that I decided, I want to gear this toward cancer. And then later on, after residency at Yale, oncology fellowship at the NCI, is when I really decided I wanted to go and work on prostate cancer, transcription factors, and metabolism. And then my early years as a faculty member was at UT Southwestern, and then later on at Cleveland Clinic. And then I was fortunate enough to come here a little over a year ago in a fantastic medical school and fantastic city.
What attracted you to the Desai Sethi Urology Institute? The founding director, so to speak, right? With Dr. Burek.
Yes. So it's really primarily the people. So interacting with and meeting the people in the leadership here, yourself, Dr. Parek, Dr. Nimer, the level of energy that exists here at the University of Miami Miller School of Medicine is really tremendous, and it just doesn't, it's not matched by any other place that I've seen. Coupled with the city and living in a vibrant international city, it was really difficult to say no to the opportunity. Both to do this as well as to really expand the level of research that we're doing, to be integrated with this powerful clinical urology program and cancer center, and doing truly human-centric translational work. That's what not only turned me on, but also turned on my team to move down here, which is not always easy, right?
And we're so delighted that you did that. And you chose to focus on a very important topic, right? A problem that affects so many men. Yeah. We know that prostate cancer is the second leading cause of cancer mortality in U.S. men. So why is prostate cancer so deadly? And what are we doing about that?
Yeah, it's a great question. Part of the challenge is that it's such a common disease. And not every case is lethal or deadly, but there's a pretty good chunk of it, pretty good proportion of it that is. And part of the challenge that we have as scientists and clinicians is to distinguish those cases, right?
When you say it's, just tell the audience how frequent it is.
So in terms of cancer-related deaths, it's above 30,000 deaths per year, about 33,000 deaths per year, but far more cases, about probably 250,000 cases per year.
Diagnosed.
Yes, that's right. Yes.
Okay, we'll continue. So what is the standard treatment for prostate cancer?
Yeah, so it really depends on what the type of disease is. So some disease, it's just active surveillance, watching it very carefully. We want to make sure we don't overtreat these men and give them side effects that they don't need for treatment that's unnecessary. So that's absolutely essential.
So let's focus on that group. So there is a cohort that can develop prostate cancer, but it's relatively benign. They just live with it.
Yes.
What are the characteristics of these people? What's different about it? Are they older or they younger? Where do you put them?
It's probably a little bit of both, but a lot of it has to do with what you see in terms of the behavior of the cells when you look at the histology. And that's actually part of the challenge, is that we primarily drive this by histology and looking at the cells, and not as much at looking at the molecular factors and molecular drivers. We're starting to do that, right? We've had some leads, but it's not a perfect world, and that's part of what we're working on right now.
So you have to be able to select which one is going to be more aggressive so you can properly target it. Is that right?
That's exactly right. That's exactly right, yes.
So let's focus now on the ones that are not particularly benign.
Yeah.
That group that can die with their prostate cancer, but of other causes. But let's talk about the ones where it's more lethal. What are the treatment options, and how effective are they?
Yeah, absolutely. So when aggressive localized prostate cancer is detected, the treatments are surgery, you take it out. Radiation is also an option in some cases. And so it's highly complex. So the idea is to be able to treat it while it's localized before it gets out. Some cases are actually diagnosed after the prostate cancer has gotten out, and now you need some sort of systemic therapy. You have to treat the entire body. And hormonal therapy has been the backbone of that treatment for 80 years. We've done better, but that's an essential part of this.
So explain to the audience what hormonal therapy is, what hormones are we talking about, and why does it work?
Right. So most of us know this as testosterone or androgens, or otherwise commonly known as male hormones, right? Largely from the gonads or the testes, but some of it comes from other organs as well, the adrenals. And so almost all prostate cancers are addicted to androgens. So they have something called a receptor for androgens, and the androgens or testosterone drives that or turns it on and basically programs them to grow. So part of the big treatment is to suppress that and to tell the tumors to stop or regress, because we've taken away this growth factor.
Got it. So the fuel for their growth is this androgen, testosterone, as you mentioned.
Exactly, yes.
And so which patients should receive this androgen deprivation therapy?
Yes. So for sure, anybody who has metastatic disease, right? So if it's outside, you can't just treat it with local therapy. You need to treat, metastatic bones, lung, liver, whatever. It has to pervade the entire body. Those men need it. And sometimes men with earlier stage disease, but it becomes kind of complex in that setting.
So what happens if you stop the androgen therapy, the androgen deprivation therapy?
Yeah. Well, usually we don't do that. Usually men who are on it stay on it. There are some cases where you might do intermittent, but it's not commonly done right now. Yeah.
is it possible for the tumor to progress even though you are depriving them of androgen therapy?
Right. So you're hitting on something that's extraordinarily fascinating, right? And so this is an observation from maybe 50 years ago, that these tumors, they'll respond, they'll shrink, PSA goes down, and then when they start to grow again, even though testosterone is low in the blood, if you look inside the tumor, you find that it's high. And it's high because these tumors have essentially become smart and decided to make their own androgens or testosterone. And that's sort of, in a nutshell, what we study.
Oh, fascinating. So the tumor now decides to have its own, I guess, manufacturing plant.
Exactly.
With testosterone,
Yes.
so it can keep growing.
Yes.
What are the characteristics of those tumors, and how do we predict which ones are going to behave like that?
Yeah, great question. So, to study that, you have to kind of get into the weeds and get into the chemistry, and we do that with a lot of pleasure. And what we've really come across is that there's a subset of these tumors, and we identify this just by work at the bench, looking at this behavior of cells from tumors of different men, derived from different men, that some have a capability of making their own androgens or testosterone really quickly, others almost not at all. And so we, basically chase this down, and this is a very common germline mutation or variant that is inherited from our parents or not. And this drives clinical outcomes and tumor resistance.
Tell us about that, because I believe you may have something to do with the discovery of that of that gene. Your seminal work was able to identify that variant.
Yeah, so I should say it's our team's work, because I'm only a cheerleader representing a number of very talented scientists in our group and physicians, and so we identified this phenotype of rapid testosterone synthesis versus very little, tracked it down to the germline. And then after that first story, which is over a decade ago, we decided to look in cohorts of men treated with hormonal therapy and asked the question, the hypothesis was, if you inherit this fast enzyme, do you do worse? Do you develop resistant disease more quickly? And does that change your overall survival? And the answer in 1, 2, 3, now 12 cohorts is yes, a resounding yes. So this seems to really predict for worse outcomes. And this is not a rare genetic variant. About, on average, 1 in 2 men inherit one copy of it.
So if you have that copy, that allows you to continuously, as a tumor cell, allows the tumor cell to continuously make its own testosterone, you are going to have a worse outcome.
That's right. That's what the clinical studies have shown to date, and it's pretty high-level clinical studies.
And what's this gene called?
It's called HSD3B1.
Okay.
Yes.
Okay. So I have to know the alphabet to be able to say HSD. Okay. Great. And your team was responsible for this discovery.
For discovering the variant and the function of the variant. Right. Yes. Right.
And tell us how this is being applied in the treatment of patients with prostate cancer. So if I get prostate cancer right now, should they be testing for this variant to make sure that if it recurs sometimes, then that's because I'm making autologous, or I guess I'm making testosterone.
Right. Yes. Yeah. So it's not, just to be clear, it's not part of the standard of care right now, but in the largest genetic study anywhere, from something called the Million Veterans Program, looking at over 5,200 men with prostate cancer. The men who get 2 copies of this gene or this variant, this is about 8 to 10% of men. This is clearly linked to prostate cancer death. So this probably makes this the most common single gene linked to prostate cancer death. So 8 to 10% versus the other thing that I think people have focused on largely is, for example, BRCA2, which is 2%. So this is far more common, and it's actionable, right? We can target this directly with drugs that we're developing. We can use this as a...
And what would those drugs do? Block?
Exactly, yes. There's at least two ways of blocking the enzyme. One strategy is one that we've actually developed a clinical trial with collaborators across the country. And the second is coming with direct inhibition. That's coming.
So this finding has the potential to completely reshape our approach to prostate cancer, or really also our understanding of prostate cancer progression, or the biology of the tumor itself.
That's absolutely true. Absolutely true. Yes.
And so why isn't it standard? What part of the standard evaluation for prostate cancer yet?
Well, I think part of it is that it takes a long time to generate the data and to move the field forward and to develop drugs. Ultimately, I think once we have effective drugs against this target, it's going to be, that's a very different thing than biomarker development or genetic development, right?
And as the dean of the Miller School of Medicine, I'm excited about the potential that these new drugs to stop this, what I call this lethality variant, would be first employed here.
Yes, absolutely. I think that's very exciting.
So are there any challenges or potential barriers to making this more widely accepted and more common in the testing itself in terms of how you test for it and then the future application?
Yeah, so we've developed generated a genetic test for this, and I think the application I don't think there are big barriers to doing that. I think the drug development is certainly the slowest part. But the other thing that I'll add to this is that as this is maturing, we want to do this again. We want to start with other basic discoveries at the bench and move that forward in a similar way, realizing it's a long road, but we need to start those roads again right now.
Great. And I recognize that this is still in an early phase of understanding the clinical application of this drug, of this variant, HSD 3B1, to be precise. You say it's an enzyme. So you also alluded to the fact that about 8 to 10% of men may carry this mutation. How should we employ this information? How should we use it for people who are either at risk of developing prostate cancer or who do develop prostate cancer? Is it something that they should keep in mind, that doctors should potentially consider in the future? Or how do we use this really novel and potentially very, very crucial information to help save lives?
Yeah, that's a great question. So I think any clinical setting in which you would potentially use hormonal therapy, this is a genetic factor that's easy to test. It's just a blood test that would tell you that the standard testosterone suppression may not be enough for a durable response, right? So that can be in late metastatic disease. It could even be applied in earlier disease. For example, hormonal therapy is given along with radiation in some settings. And if those tumors are more intrinsically resistant, then they may need something else that will improve overall survival.
Absolutely fascinating. So since we know that there are several other cancers that are also hormone sensitive, and so how does this finding potentially influence your approach to other such cancers, such as breast cancer, for instance?
Yeah, so it's a great question. So this enzyme is in the androgen synthesis pathway, but it turns out that for women to make estrogens, the body has to make androgens before it makes estrogens, and is converted by an enzyme called aromatase. This enzyme, this gene is directly should say that again for the audience? Yeah, so this gene is directly upstream of aromatase, which is needed to make estrogens, particularly in postmenopausal women. So we've begun some investigations in breast cancer. It's not nearly as mature as it is in prostate cancer, but it shows a potential application in some estrogen-dependent breast cancers.
So how would you use that information to manipulate or optimize therapy in those particular breast cancers?
Yeah, so just like the way we're thinking about this for the prostate cancer clinic, if we have knowledge from the very beginning, from the point of diagnosis for a woman who has estrogen-dependent breast cancer that tells us, you know what, this tumor may not respond as well to standard therapies. Maybe we need to think about something else. So that goes into that aspect of research right now that we're looking at in various settings with collaborators.
This is fascinating. Not only we have the linkage here between estrogen and testosterone, but we're just looking at the linkage now between prostate cancer and breast cancer.
Yes.
There you go. So tell us, you've also been doing some work looking at the influence of diet.
Yeah.
Tell us a little bit about that in terms of how it potentially influence the development of prostate cancer.
Great. So there's a lot of evidence out there that diet has some link to both developing prostate cancer and potentially prostate cancer progression. But a lot of this is really population level data, which is exquisitely important, but we really need to understand this better on a per person level, on a molecular level, in terms of what we need to take in more of or take in less of, right? Or perhaps even how much of certain things we need to do. So we've actually, to that point, we're starting a first of its kind study with a metabolic kitchen in men who are undergoing surgery for prostate cancer to figure out what specific diets, for example, low fat versus low carbohydrate, does to the prostate cancer at the molecular level.
That's fascinating because that's what's going to ask. I was going to ask you, should I go on a broad diet? Should I become a complete vegan, or can I continue to enjoy a burger and fries?
Yeah, it's a great question. I don't think we've answered it definitively. I think generally animal products are probably not great. Probably eating less and eating more of other things is better. But I think we have a long way to go to really understand this. And in terms of how two very different men with very different genetics might have different requirements or different predispositions. So we need to really kind of get in the weeds about this.
So how would you set up a study to test the role of diet or to test how diet influences the development, progression, or aggressiveness of prostate cancer? That seems to be a daunting task.
It is a daunting task. And it's something that, we need not just one team, but many teams and collaborators to really do this very well because it's incredibly sophisticated. There's population science, there's genetics, there's metabolism, there's nutrition. And then, of course, if we want to study the molecular details, there's a molecular biology aspect. So we have to do this with, in conversation with people from around the world who have expertise in areas that we don't have expertise in.
So do you envision subjecting a cohort of study patients to a particular diet for a long time? If so, how long is long enough?
Yeah.
Because unless we know exactly how prostate cancer evolves and when the critical mutation takes place and you develop the cancer, it's hard to know when dietary modifications will be most effective.
That's right. So I think it's critical before doing these longer term studies with, clinical endpoints and survival endpoints that we study this at a more basic level. Part of what I'm really excited by doing right now is what we're pairing with this dietary intervention study is the capability. So right now when a tissue comes out for cancer surgery, we look at proteins, we look at the cells, but when we look at metabolites, we just look at concentrations. We don't know anything about the spatial distribution. Where is the fatty acid? What cells are they in? And so we're going to do that as part of the study, actually, prior to with two different diets, figuring out what that does to the distribution of metabolites in the tumor itself that comes out of a patient. And I think that's part of the starting point to understanding the basics and then moving forward with longer term clinical studies.
We got it. So you think that exposing someone to a particular, even for as short as a few weeks, in 3-4 weeks.
Yes.
And then take out the tumor, that would provide very useful information in terms of the biochemistry of where things are located.
Yeah, absolutely. I think that's an essential starting point for doing the longer term studies.
And how will that help you shape the longer term study? I mean, and I'm still kind of baffled by how long do I need to be on that diet if I want to reduce the risk of developing a particular type of cancer, especially prostate for men.
So to be clear, I love cheeseburgers as well, and it's going to be hard to take that love out of me. But a starting point, for example, that I envision for this is you take two different men, give them the same diet, and when you look at the tumor tissue or even the normal prostatic tissue, let's say you have two very different findings, two different distributions, and then you identify the genetic basis for that. Now that's a good handle to figure out who might need different dietary intervention for prevention, or even once they have a tumor, to prevent progression.
Fascinating. So you really, to get at this, to appropriately answer this question, you have to have a multidisciplinary approach. And that's the take-home message right there.
That's
because,
right.
As you mentioned, you're working with the nutritionists and others, different teams and so forth.
Yes.
So tell us a little bit about that.
That's, in many ways, that's the best part of this job, right? Is the people, and people coming from different backgrounds. It's the best part about the job. It's also exquisitely humbling because no one person can do everything, right? So I may know certain things about, some aspects, but I need other people who are great chemists or great analytical chemists or great drug developers or great geneticists providing the expertise that I can't provide. And it opens up new areas of investigation, but it also opens up my mind to thinking about things in new ways. That's in many ways the best part of this job.
And how do you keep all those egos working together? The geneticist, the nutrition and metabolism expert, the physiologist, and the urologist.
So I'll tell you from my own personal perspective, I think doing science and looking for scientific discoveries, it's a very humbling process, right? So I always tell people in my group, you have to have a hypothesis. But just be ready, because usually your hypothesis is incorrect, right? And whatever it is, you have to be driven by the data. If the data says you need to turn left, not right, even though you want to turn right, then you got to turn left. That process is incredibly humbling.
And that's why we do the experiments.
That's right.
Hypothesis driven and mechanism oriented, and we have to deal with the facts.
That's right.
Well, that's fantastic. So what advice do you have for young aspiring medical students, and recalling where you were when you were back in Pittsburgh in particular, and where you are now? I mean, what advice do you have for those who aspire to become physician scientists, very much like what you've done?
Yeah, so this is probably my most important advice that I would volunteer, is that, when you're training, when you're see yourself, doing the kind of work that you want to do, make sure you go after something that's foundational. And when you have a finding, it's something that will withstand the test of time, that's durable over the long period of time. Don't go after the flash. Don't go after the immediate attention, because oftentimes that will bias you in a way that ends up with science that's not durable. So just make sure you do things that's foundational, step by step, and for the right reasons, and don't let anything get you off that track.
Oh, fantastic. And I think this is very practical and quite significant for our students. And for the rest of the men out there, but to some extent women also with breast cancer. So tell us your prognosis about the future of prostate cancer. What's on the horizon, and can we count on your seminal work to finally bring that holy grail?
Yeah, I think the future is actually very, very bright, and it's not just our work that's moving things along, but science in general. As we're moving things along, I think there's going to be a lot of advances in prevention, earlier diagnosis, preventing overtreatment, and better, perhaps even curative treatments for men who have metastatic disease, and to reverse that lethality, allowing men to spend better time with their loved ones. And that's ultimately what the goal is here.
It's fantastic. Well, Dr. Sharifi, it has been a fascinating half hour, and thank you so much for sharing your expertise with me and the rest of our audience. And it's been quite enlightening, and we are counting on the success of your scientific discoveries to bring some hope, especially for patients with metastatic prostate cancer who carry that variant. So I wish you the very best of luck. I wish you the very best for our society, because your work is so important for our future. So, and personally, as the Dean of the School of Medicine, it is such a privilege and a pleasure to work with you and to have you on our faculty. So thank you for being here.
Thank you so much, Dr. Ford. It was a pleasure to be here.
Great. And this has been another episode of Inside UMiami Medicine with the incomparable Dr. Nima Sharifi, director of the scientific director of the Desai Sethi Urology Institute. Join us next time for another podcast on Inside UMiami Medicine.